talk about the urinalysis. Join me, shall you? Please only order a urinalysis if you're specifically looking for something. According to the United States Preventive Services Task Force, they recommend against screening urinalysis. And the reason being is because it leads you down a lot of rabbit holes, a lot of unnecessary extra work for you, and a lot of unnecessary tests for your patient. So that means that every single patient who comes to you for a physical, you don't do a urinalysis on every patient. Only if you're specifically looking for something. Now, you order the urinalysis, this is what you get on the right-hand side. You get all those components. We're going to go into great detail on several of these components, but let's just breeze through some. Color, that's color to the visible eye. Clarity, how clear is the urine? Bilirubin, that is conjugated bilirubin. Bilirubin results from the normal breakdown of the red blood cell. It's yellow. We have a little bit in our urine, but not enough for the machine to pick it up. Specific gravity is the weight of the solution versus the weight of equal volume of water. In other words, it's measuring the weight of the contents of the urine. 1.008 to 1.022 is normal. So it's measuring both the number of particles, I should say, and the size of those particles. Urine osmolality, which has to be ordered separately, is determined only by the number of particles in the urine. But see, we shouldn't have large proteins in our urine. We shouldn't have large particles. They can't filter through the glomerulus. So if we have large particles in our urine, there's something wrong with the filtering system of the glomeruli. The pH is often to check for metabolic acidosis. The appropriate response to acidemia is to excrete urinary acid. Nitrite. Bacteria release nitrate reductase to convert nitrate to nitrite. They use nitrite to generate their ATP. But some bacteria, like gram-positive enterococcus, do not release a lot of nitrate reductase. So a patient can have a UTI and still not show positive nitrites. It only will be positive if the specific bacteria is one that converts nitrates to nitrites for energy. Generally, you'll see more of the enterococcus in hospitalized patients. Leukocyte esterase is released by lysed white blood cells, or white blood cells that have been ripped apart. So again, a sign of an infectious or inflammatory process. We'll talk more about glucose. Glucose, pretty much, it's going to be your diabetics. Ketones signifies a breakdown of the fatty acids being used for energy. So the body has started to dip into the energy reserve system. Protein is mostly going to be albumin. And then the white blood cell, the red blood cell, the epithelial cells, and the bacteria, that would come with microscopy. So you would have to order those last 4 rows separately. And we'll talk about when and why and so on. Notice when the patient taps their kidney, we don't want to check what's on the tip of the urethra. We want to check what's inside. So have them pee into the toilet first, stop the stream, and then fill up the cup. And then notice step 9, you give it to the happy nurse who has the huge smile on her face because she is getting a urine cup. Microscopy is manual. That has to be ordered separately versus the automated, which comes with the urinalysis. So with microscopy, you're going to be getting an evaluation, a microscope evaluation of the urine. Also, culture and sensitivity has to be ordered separately. And culture and sensitivity is designed to grow and identify the bacterial organisms and their antibiotic susceptibility. It takes a few days to get the results. Okay, so you order the urinalysis. That is just the run-of-the-mill dipstick. But if you order microscopy, that is where either you, if you get trained up in it, or the lab professional looks at the urine now under the microscope. And one of the things that is being evaluated for is urinary casts. And urinary casts are cylindrical structures formed under certain conditions. Now you have cellular and acellular casts. Cellular are your red blood cells and your white blood cells. Red blood cells are always pathological. So you can see it with glomerulonephritis, you can see it with lupus, good pastures syndrome, and we're going to talk about these. White blood cell casts are indicative of inflammation or infection. With inflammation, that would be due to nephrotic syndrome. You can see it with post-strep glomerulonephritis. And then acellular, we have fatty casts. Fatty casts are due to the breakdown of epithelial cells. So that would be indicative of usually nephrotic syndrome. Granular casts may be composed of degraded cell lysosomes. They are attached to proteins. Granular casts are most often indicative of acute tubular necrosis. You can see them if someone exercises very vigorously and then does the urinalysis, but more often than not, it's going to be acute tubular necrosis. And again, we're going to talk about all these diseases too, so by the end of the lecture, hopefully this will have all come full circle. We have waxy casts, the end product of cast evolution. So there has to be lots of time spent where they're just sitting in the kidneys, festering and building up. So if waxy casts are seen, that's going to be suggestive of very low kidney flow. Those casts have just been chilling, they've just been hanging out in the kidney, building up. So you'll see that with end-stage renal disease. And then hyaline casts, you're not going to get a lot of information from those. You can see that with low urine flow, concentrated urine, acidic urine, so patients who are dehydrated or exercising a lot. Also, if you perform microscopy, there's going to be an evaluation for crystals. I don't have a slide on this, but the crystals can help you, as the nurse practitioner, identify the causes of a kidney stone. So you can see uric acid crystals, you can see calcium crystals, cysteine, or magnesium ammonium phosphate crystals. And we'll talk about those when we talk about kidney stones today. Okay, I want to go back to the urinalysis now. We laid the groundwork. We laid the groundwork of the components you get. We laid the groundwork of microscopy. Let's jump right in now. Let's go into the deep end. Color. Red is indicative of hematuria. Brown would be myoglobin. Myoglobin would be secondary to muscle breakdown. So there's excessive muscle breakdown, like in rhabdo. Orange urine can be seen with dehydration, jaundice, or certain medications, like pyridium or rifampin. Rifampin would be used for tuberculosis treatment. Clarity. If the dipstick result is cloudy, that can be due to bacteria, that can be due to protein. It's not very, it's not going to give you much information. It just pretty much tells you there's something going on, but it's up to you to work it up now. So it's not too helpful. Bilirubin, again, that's going to be conjugated bilirubin. It's the normal breakdown of red blood cells. It's yellow in color. That's why our urine is yellow. So if the dipstick says positive bilirubin, think liver etiology. There's something going on with the hepatobiliary system. See, the urinalysis only can check for conjugated. Unconjugated bilirubin is tightly bound to albumin. It's not filtered by the glomerulus. So this is only conjugated bilirubin. So then high specific gravity is going to be a concentrated urine. You'll see that with dehydrated patients, patients who have had diarrhea, vomiting, or sweating, or prolonged exercise. You can see it with congestive heart failure because the patient is retaining their fluid. You can see it with infection or diabetes where glucose is spilling into the urine. And then low specific gravity would be very, very dilute. So diabetes insipidus or psychogenic where the patient is just pounding water all day long. You can see it with renal failure. You can see it with interstitial nephritis. So pretty much with low, just remember, very, very dilute, high, very concentrated. Hematuria. These are the main diagnoses, the main etiologies of hematuria. So let's go over how to work up blood in the urine. All right, so hematuria. On the dipstick, meaning the run-of-the-mill urinalysis, the run-of-the-mill, the patient taps their kidney, it's just going to tell you yes or no. Blood positive, blood negative. That's it. So you need to do a lot more assessment with that. That doesn't tell you much at all. Number one, is it gross hematuria or microscopic hematuria? Gross hematuria means you look at the urine and you see blood with your human eye. The next thing you would want to assess for is, do you see little clots in that urine? That's a sign of urinary obstruction. You'd want to get urology involved in that case. Microscopic hematuria, it's seen only under the microscope or the dipstick. So it's found incidentally. So the patient's not going to come to you and say, I have microscopic hematuria. They can't see that. You can't see that. Only the machine can pick that up. Number two, is the source actually renal? A female who is on her period, that's going to show as positive hematuria, but it's not a renal source. Medications, pyridium, rifampin, phenytoin, nitrofurantoin, they change the color of the urine. So the dipstick says, yeah, that looks like blood to me, positive. It's not blood. It's just these medications are changing the color of the urine. Patients who consume a lot of beets, it's going to change the color of the urine. Number three, is this due to other benign causes like vigorous exercise? If the patient did some really strong exercise within 24 hours, it has the potential to show positive. Inadequate hydration. So if you see hematuria secondary to an elevated specific gravity, maybe the patient just isn't hydrated. If the hematuria is microscopic, number four, is it true hematuria or not? True hematuria is 3 or more red blood cells per high-powered field, so hence you need microscopy. You cannot diagnose hematuria without microscopy because you need someone to actually look under a microscope and count the red blood cells. And that patient counting the red blood cells is going to rule out medications, is going to rule out myoglobinuria, which is myoglobin or rhabdo, because that's not going to be red blood cells. So it's going to rule out all that stuff. It's going to rule out semen, which can cause hematuria in some cases on the dipstick. So I just want to reiterate that. The dipstick is just going to say positive or negative. You need microscopy to give you, number one, is this true hematuria? And number two, it gives you a defined number. 3 or more red blood cells per high-powered field is hematuria. Less than 3 is not hematuria. If the patient has less than 3, you just repeat the microscopy every 6 weeks for 3 times. The patient just comes back. You don't need to see them for a clinical visit. They just go to the lab, tap a kidney, you do a urinalysis and a microscopy. If all of those 3 repeats are less than 3, you just check a urinalysis every year. You just want to make sure that it's not getting worse. But if any of those repeats show a red blood cell of 3 or more, you're dealing with true hematuria and you need to work that up. Even if it's just one of the repeats, you work it up. Okay, so let's talk about how you work up true hematuria. And again, this is 3 or more red blood cells per high-powered field. Number one, is this coming from the glomeruli? If you see red blood cell cast or proteinuria, odds are good that it's coming from a glomerular source. In most cases, you're going to want some help from nephrology to work that up. And I want to save that workup for proteinuria, because now you're going to go into the proteinuria algorithm. Let's say on the microscopy there's no red blood cell casts, and on the dipstick there's no protein. Well, then you're more likely dealing with a non-glomerular source. So number one, does the patient have signs of a UTI? If the patient has leukocytes or nitrites, you're dealing with a UTI. Treat the UTI. But then don't ignore the blood. After the patient finishes her antibiotics, I say her because by and large UTIs happen in females, then have her come back in 4 to 6 weeks and just repeat the urinalysis. That blood should have cleared and you don't have to do anything else. It was just secondary to the infection. But let's say the patient has no signs of an infection. There's no white blood cells, there's no leukes, there's no nitrites. Well, the second most common cause is a kidney stone, nephrolithiasis. So does the patient have flank pain? It's generally one-sided, but it can present as bilateral flank pain. So does the patient have any flank pain? Does the patient have a history of kidney stones? If yes, grab a CT scan. Now, you'll notice on your algorithm, go to kidney stone and notice, yes, it says non-contrast CT of the abdomen. While you are assessing for kidney stone, also in the back of your mind, consider for malignancy. Bladder cancer, kidney cancer, they all present with hematuria. So, does the patient have a family history of urinary cancers? Does the patient smoke? Is the patient greater than age 35? Does the patient work in a chemical plant? That would all increase your thoughts, man, this might be malignancy. If you are concerned of malignancy, say, this could be a kidney stone, or this could be malignancy, grab a CT urogram with and without contrast. If you're not concerned for malignancy, you're just thinking, let's rule out a kidney stone, go without contrast. And that summarizes the whole second half of that algorithm. You just combine those two. So I just want to reiterate, kidney stone or malignancy, with and without contrast. Low concern for malignancy, but you want to rule out a kidney stone, go without contrast. This is just another way to look at hematuria. Some some students find this easier to interpret than the other one. So if you think you got hematuria down, just skip ahead to the next slide. But if not, let's review this one. So number one, are you dealing with true hematuria or not? And true hematuria is 3 or more red blood cells per high-powered field on microscopy. If microscopy comes less than 3, you repeat the urinalysis with microscopy every 6 weeks for a total of 3 times. If any of those 3 repeats show red blood cells 3 or more, then that's hematuria. That's all you need to start working that up. If all 3 are less than 3, then you just check it every year or so. Just make sure it's not getting worse during their annual physical. That's one of the times where you would do a screening urinalysis. Patient has 3 or more red blood cells. Well, have they been rigorously exercising? Is it a female on her period? Make sure this is coming from a renal source. If the patient has been vigorously exercising, tell them, give it a few days, come on back and repeat it, but don't exercise the day before. Let's say it's positive. Well, is it secondary to a urinary tract infection? If it is, treat the urinary tract infection. You don't need to do further workup. And just have the patient repeat the urinalysis in about 4 to 6 weeks after treatment is done. It should have resolved. If the blood did not resolve, it wasn't due to the urinary tract infection. There's something else going on. So then, let's say the patient doesn't have any signs of infection. You need to determine the risk of malignancy. Are you concerned for a bladder cancer? Has the patient been exposed to certain chemicals? Does the patient smoke? Does the patient have a family history? Then you'll probably want to do a CT with and without contrast. If your concern for malignancy is low and you just want to rule out a kidney stone or rule in a kidney stone, a CT without contrast is usually plenty sufficient. Patient says, I have blood in my urine. All right, so number one, are you dealing with gross or microscopic hematuria? You're dealing with gross hematuria. Shout out to Ben Franklin, by the way, for coming up with the idea of libraries. Much respect, Uncle Ben. I give you a salute. 45-year-old presents with 1 day of bright red blood in his urine. He denies any pain, frequency, or hesitancy. Denies any fever or chills. Has some mild lower mid back pain. He denies smoking. He denies any history of kidney stones. So notice on his vitals, his heart rate is kind of up there. He is obese. And on the exam, he has CVA tenderness. So you check your urinalysis. The patient has a urinary complaint, so you do a urinalysis. Is this actually from a renal cause? Yeah, probably. I'm not concerned. I mean, he's not consuming a lot of beets. He's not on any medications. So yes. Is this true hematuria? So jump on down there to microscopy, look at the red blood cells. Is it 3 or more? Yeah. So this is true hematuria. Is it due to an infection? No. On the dipstick, he has negative leukes. He has negative nitrites. On the microscopy, he has negative white blood cells. No bacteria. He has no infection. Is it coming from a glomerular source? Well, does he have protein? No. Does he have red blood cell casts? No. Now, let's say he would have signs of an infection and he had protein. Then just like before, you just treat the infection, have him come back in 4 to 6 weeks and repeat. So if it's an infection, even if there's protein or not, just treat the infection and then have him come back. Does he have symptoms of nephrolithiasis? Yes, he has flank pain. Are you concerned for malignancy in this guy? Well, he is 45, but we don't know his family history, but let's say his family history is negative for malignancy. Let's say he's a non-smoker. My concerns for malignancy are pretty low in this guy. I would start with a non-contrast CT of his abdomen and assess for kidney stones. So that should be your next step. You could make the argument for a with and without contrast, but me personally, I would start without contrast. So that's hematuria. We're going to come back to Ben Franklin again. We're not done with him. But let's move on with our urinalysis. pH is checking the acidity of urine. So low would be uncontrolled diabetics, people who are starving, literally starvation because of metabolic acidosis. High, you can see with bacteria, a diet rich in citrus. You can see it with overuse of perineal cleaning agents. Nitrate. Remember, the bacteria needs to convert nitrate to nitrite, so you can still have a UTI, but have a negative nitrite. And then leukocyte esterase. Now, if the urine is exceptionally concentrated, if there's protein, if there's glucose, that can cloud the results on the leukocytes. They're still there, but the dipstick can't pick them up. The computer can't pick it up. Okay, glucosuria, you'll want to check a serum glucose. Now, let's say you have a known diabetic. You're treating him for diabetes. You know he's diabetic. Would glucosuria alarm you? It shouldn't, especially if that patient is on an SGLT2 inhibitor. You should expect to see glucose in that patient's urine. You know, you're not going to do any treatment or anything based off of glucosuria. You're going to go off serum. Now, let's say the patient has a positive glucosuria, but the serum is fine. That's a sign that the glucose is not getting reabsorbed like it should, and there's something else going on. You can see that with multiple myeloma, cancer of the plasma cells of the bone marrow. Likely, those patients will also have normocytic anemia, bone pain. There'll be other signs and symptoms. We'll talk more about multiple myeloma soon. Ketonuria, that would be for DKA, diabetic ketoacidosis. Now, we have three ketone bodies: acetoacetate, beta-hydroxybutyrate, and acetone. Beta-hydroxybutyrate is the predominant ketone body in severe DKA, but it's not picked up on the dipstick. So it would be very rare, but not impossible for the patient to be in DKA and have negative urinalysis. That's our endocrinology lecture. Proteinuria. Proteinuria is the hardest thing we're going to talk about today, in my opinion. So please bear with me. We have case studies. I'm going to attempt to make this as clear as I can. Proteinuria, generally the patient has bubbles in their urine. It looks like foamy urine. And that's because globular proteins like albumin, which is what is picked up on the dipstick can't pick up non-albumin protein. And albumin protein has hydrophobic regions and it has hydrophilic regions. Those hydrophilic regions align in water and push the hydrophobic regions into the air. That creates a surface tension that seeks to minimize the air-water interface, resulting in bubbles. Gross hematuria can cause a false positive proteinuria. So with the proteinuria, again, on the dipstick, it's going to say positive, it's going to say negative, and that's it. You gotta get more specific than that. So you have an option on what to do next. Option number one is have the patient do a 24-hour protein excretion collection. That's probably your most accurate option, but that is very, very cumbersome. So an alternative that is used far more often is to just do a spot morning urine protein creatinine ratio. So the patient just comes in the morning, does just a spot urine, and the ratio of the protein to the creatinine is measured. And then you take that number, that ratio, and use this calculator that you see here and type in the answer, and it will correlate with the 24-hour. It correlates very, very well. I would have the formula here, but it is insanely difficult. It involves logistics and I mean, it's insanely long. So generally, just use a calculator.